Oh, hey, it's Dr. Zeitham with Trauma.
Oh, that's right. I always say his name wrong. 2 years, I still say his name wrong. I'm going to give it just a minute or two for people to get on. Next month's going to be huge. Next month. I want to thank Dr. Whitwer and Mark for allowing us to come and talk at your meeting today. We here at the trauma program have come up with, we're constantly trying to improve our program and improve our processes. And this year, in collaboration with the emergency department, we came up with some initiatives to help improve the process in the emergency department. And one of the things that came out of this is a new EMS trauma report. And what I mean by that is what we want the medics to say when they come in and give us report on a trauma patient. This only affects trauma patients. You can continue to give your reports on other ED patients, however you're normally doing so. And this isn't crazy different from what you're used to. So in my own position, you know, the hospital on a regular basis tells me I have to do different stuff and more stuff, do stuff and different stuff. And I often ask myself, why? Why are you doing this to me? And like I said before, this is part of our continuous process improvement. Number one, we want you to get the undivided attention you deserve when you're giving report. What you're telling us is important, and we want people to be able to pay attention to that. So while you are talking, pretty much all of the rest of the room should be entirely silent, and you should have the attention of the primary nurse and both of the physicians in the room. And then conversely, the emergency department physician, the trauma physician, we need to find out quickly what we need to know. And the sicker the patient is, you know, unfortunately, the paradox is the more you have to say and the faster we need to know what's important, and what's important becomes very streamlined and focused in that situation. A big thing for the emergency department is crowd control. So we don't have beautiful big trauma bays. Those rooms get crowded fast, especially if you're in one of the rooms where you have another patient on the other side of the curtain. So we need fewer people in the room as often as we can make that happen. And then reduction of noise level. It gets so loud that nobody can hear what's going on, and that reduces our efficiency. It means we take too long getting the patient evaluated, getting the patient to the scanner or up to the operating room if that's what needs to happen. And then again, the primary nurse doesn't want to miss any information. What you're telling us is important, so we want to give you the spotlight to tell us what's important and to give us that information. So this is going to be in the trauma rooms, in the critical rooms at least. Now, if you know, bring a trauma to fast track B, that's probably not going to, you're not going to see this. But in 33 through 36, when you bring them into our normal trauma rooms, this is what's going to be up in some place that you'll be able to see it as a reminder. If you look through it again, it's not that different than what you do now. We just want it more concise and to have some important things that sometimes are missing from the reports. And that 30 seconds is really being generous. One of my mentors once said, trauma surgery is the specialty for whom instant gratification is not fast enough. So those of you who know trauma surgeons, we want to know right now, and we want it done because we thought of it. So again, age and sex, that's pretty standard. Injury time, and this doesn't have to be at 4:02 someone crashed their car, but 30 minutes prior to our arrival, you know, just before we were dispatched 30 minutes ago, you know, right out in front of the hospital 5 minutes ago, yesterday at 4 in the afternoon, something like that. So an injury time mechanism. You know, again, this is a quick and dirty. Jumped off a bridge, fell out of the back of a pickup truck, motor vehicle crash, head on, T-boned, rear-ended. Very brief. Initial GCS. We're really going to want you guys to hone in on your GCS skills. So when you arrived on the scene, the patient's GCS was what? And that means eyes, motor, verbal, right? Motor is most important for us, especially once you intubate them, but eyes, motor, verbal, right? And especially, you know, are they confused? Are they moaning? Are they saying things that don't make sense? Are they following commands? Are they localizing? Are they posturing? Are they doing nothing? So initial GCS, and then the last GCS that you were able to get. Last set of vital signs, and then a key one I wish I had a little in presentation highlighter is lowest blood pressure. So when you guys get a blood pressure in the field that's less than 90, that's a big marker for us. And even if the patient improves when you do something, if you intervene and their blood pressure comes up, for us, that's still a real blood pressure. We call those folks transient responders, and it may mean that they're bleeding and they're going to try and bleed to death on us once we move them to the table. So that's an important one for us. Type of vascular access, and then significant findings and interventions. This is also fairly brief. You know, if somebody has abrasions everywhere, we don't need to know about every single abrasion, but we didn't have breath sounds on the right, so we needled his chest or something like that. I've got some examples coming up. So what you found and what you did, and then medications provided in the time of administration, relevant prior medical history, allergies, and home meds. And then as a lot of you know, the bulk of our business these days are the elderly people who fall down. We are getting a lot of people in their 80s and 90s are coming into the hospital from facilities that should have a pulse on file. If you can get that or have their code status, that is key. Unfortunately, when people don't want to be on a ventilator and don't want to be intubated and don't want resuscitation and they show up at the hospital with trauma without that piece of paper or without us having any knowledge of that, a lot of times those things can happen against what they want in terms of their care at this point in their lives. The report is complete when you guys ask if there are any additional questions. So from the time you start until you ask if there are questions, there should be silence in the room and all eyes should be on you. Once you ask that, then we're going to ask you not to continue to talk to the primary nurse. Everything you need to tell us needs to be in that box at that time. If you need to come back in later and talk to the nurse about something or deliver paperwork or get a signature, that is fine. But the primary nurse, as soon as you're done giving reports, her job is then to start recording what we're doing in terms of exam and intervention. So she needs her attention on what we're doing, and she can't have that if you're still talking to her. So the other thing is, as soon as you ask that, and nobody has any questions for you, we're going to ask you to leave the room. And again, it goes back to that crowd control point. And Dr. Zeithamel has something to add here.
Hey, so one of the things that we have difficulty with, I know sometimes, is the whole description of the mechanism. And there's a lot of details given. And remember, I think that EMS classically is trained because the details of like an MVC, the degree of intrusion, or the length of the skid marks, that helps us identify what to look for in terms of the injuries in a trauma patient. Remember, now everybody gets scanned, so there's really not much about the mechanism of the injury that's going to change what we do, with the exception of just knowing it's an MVC or if there's a death in the vehicle. But we're going to give them the same workup, no matter if they were rear-ended, T-boned, in general. So that, I think that they're doing that because they think that it drives what we do or what we look for. But the truth is we work most trauma patients up the same way. So that's just a piece of information for them.
All right, so here's an example. This is an 89-year-old woman. At 1 o'clock today, she fell backwards off 3 stairs, struck the back of her head, had a positive loss of consciousness. Her GCS, when we arrived on the scene, was 14. She's now 15. Here are her last set of vital signs. Her lowest pressure was 92/44. We have an 18 gauge in the left AC. She's got a lac on the scalp, a deformity and swelling of the left wrist, which is splinted. We gave 100 mics of fentanyl 10 minutes ago. She's on no blood thinners. There's no pulse available. Any questions? Way less than 30 seconds. So you have some room. And we know this is, it takes some time to get muscle memory in. If you do have questions, go ahead and put them in the chat window right now. Another example. This is about a 25-year-old male. 45 minutes ago, he was run over by a truck. Initially, his GCS was 9. He's now a 3T. These are his vital signs. His lowest blood pressure was 82/40. We've got 2 18 gauges for access. We intubated for a low GCS. Initially, he had no breath sounds on the right, so we needled his chest. He was hypotensive and received 1 liter of normal saline bolus with improvement. There are abrasions to the chest, and his abdomen is distended. His meds include succinylcholine for intubation, 100 mics of fentanyl, 4 milligrams of Versed coming in 5 minutes ago. We don't know his prior medical history or his code status. Are there any questions? And it doesn't have to be rigid. So that same patient is a 45-year-old male run over by a truck 45 minutes ago. His initial GCS on the scene was 9, so we RSI'd him with succinylcholine. Lowest blood pressure was 82/40. He got 1 liter of normal saline with improvement to 100/58. He also had no breath sounds on the right. I needled his chest with improvement. Last vital signs: blood pressure 100/52, heart rate 120, respiratory rate 16, standing 100% on the vent or on with the tube with bag valve mask. IV access is an 18 gauge in each AC. Other findings include abrasions to the chest wall and his abdomen is distended. We gave an additional 4 milligrams of Versed and 100 mics of fentanyl during transport a few minutes ago. Unknown prior medical history or code status. Any questions? So you see, you have some room within that diagram to cover all the things we want covered. Some people think like this slide here. Some people think like the first slide. And that doesn't matter how you go about doing it. Personally, I would give the second report rather than the first report. But we just need, this is the information we need and pretty much the only information we need. Now, this is one of my favorite things that came from the CDC. This is a CDC field criteria for triaging traumas. This is where the trauma system gets information on what we decide is going to be a trauma or what's not going to be a trauma. High-risk automobile crash, intrusion, including roof intrusion, greater than 12 inches into the occupant's site. So that's not how much the front of the car is crunched up or how much the back of the car is crunched up, but how much intrusion into the passenger compartment occurs. As Dr. Zeithamel said, almost all of these patients are going to get the same CT scan that looks for injuries. So when you show us pictures of the car, it adds nothing to our evaluation of the patient. I'm just going to tell you, the cars nowadays are meant to crumple and be completely crushed, the front and the back, and the passenger compartment relatively intact. If you tell me in report there was 2 feet of intrusion into the passenger compartment, or the engine block was sitting on the patient's lap in the passenger compartment, that has a little bit more significance for me. Again, though, however, we're going right to scan, and I don't want to see a picture unless I'm bored and I don't think the patient's sick and I'm just curious. But in terms of what it's going to do for us clinically, it's not going to help us clinically make a decision about how we're going to take care of that patient. Back in the day when all of this started, when Henry Ford built his first factory, he was putting cars on the road built for the car to survive. Okay, those cars on not paved roads, they were going over country roads. If any of you have ever driven on a country road, there's lots of potholes. If you've ever driven over cobblestones in Philly or Baltimore, it feels like you're going to shake your spine right at the top of your head. Cars used to be built for the car's survival, not for the driver's survival or the passenger's survival. That's different now. And so all of those things we used to do in trauma, and I learned exactly the same things when I was a medic, don't apply as much anymore. Crumple zones. And once again, I just want to reiterate that we ask that after your report, you immediately exit the room. And it's not that we don't love you and we know you're interested in what we find and what's going on and what's going to happen with the patient, but it gets really crowded and really loud. You are welcome to throw the patient information up on the whiteboard in the EMS room, and we will, as we've done in the past, come out and try and give you some follow-up on what we found. You're welcome when you come back around on your next run to, if you see the trauma surgeon, ask and find out what we found. We want to provide you with that feedback. We just need you not in the evaluation room after you're done with reports. Questions? All right, we understand this is going to be a little bit of a work in progress, and understand that trauma surgeons also need to develop new muscle memory, because this will be new for our group as well. Nobody should get mad at anybody, and if you have issues or questions or problems, you can certainly send them to Dr. Whitwer, and he knows how to get a hold of me. You can get hold of us and let us know. We don't want this isn't a thing to be mean. We just need to change our process to help the emergency room function more efficiently. Dr. Seidhammer?
Yeah, that was nothing to add. That was good.
All right. And Dr. Seidhammer is moving into a position as our liaison between trauma and the emergency room. He's got a bunch of other initiatives, so feel free, if you see him down in the ED, to pick his brain or talk to him or provide suggestions. He'd love to hear from you. All right, I think we're done, Mark.
Okay, thank you.
Thank you.
Thank you, guys. Appreciate it. Okay, everybody that's hanging out, still bear with us. We're going to switch over to Dr. Mock.
Good morning.
I think that picture of the crowd, I think everybody who's got a color shirt on has probably got COVID.
And give us a minute while we work through some technical details. Mark, I'm going to ask that you make my other account the presenter. I'm getting audio from one source and video from another.
All right.
Thank you. Morning. I have two topics to talk about today, both focused on COVID. It should be fairly brief and focused, but before we dive into the brief and focused stuff, I want to talk a little bit about the big picture. So I know that at this point, we all expected that things would be better with respect to disease transmission. We all hoped that things would be better. But unfortunately, that's not the case. This is the most recent Clark County data. And so we are continuing to see a rise, and the curve is spiking as much as it was in April right now. We certainly have more hospital capacity, more testing capacity, but I just want to acknowledge a couple of things. One, this is really difficult. There's a lot of fatigue that comes for everyone working in healthcare dealing with this. Second, I just wanted to acknowledge that it is a tremendous accomplishment that we have not had work-related transmission of COVID yet, and that reflects a great deal of discipline and attention to detail on all of your parts with respect to the PPE. And so I know it's fatiguing, and I know it's been going on a long time, but I just want to commend you on that. It speaks a lot to your professionalism in what you do. So first, we're going to talk about refusals. And so what we're seeing with the coronavirus is that more and more people are refusing care. Sometimes this is appropriate, and sometimes it's not. We're going to delve a little bit deeper into one aspect of the protocols to make our expectations about this clear. And in the next protocol update, we'll make some edits just to make it a little bit more clear and user-friendly. So what's going on with refusals? Excuse me. So this is data from January through May, the transporting agencies, they're reporting to WMCIS. So what's in blue here is transports. What's in black are patients who are refusing care, AMA. So pre-pandemic, January and February, we were seeing about 6% of all patient contacts were ending in refusals. March jumped up to 10%. April stayed around that number, even with the decrease in calls. It's coming down slightly in May and slightly in June as well, but it's just a more common thing, either because people are hesitant to come to the hospital because of fear of contracting COVID, or people just have more desire for telemedicine care at home. So we're going to go through a couple of cases and then talk about how to approach them. So case number one, you dispatched on a motor vehicle collision. The patient is a 25-year-old female. She was a restrained driver, moderate mechanism, MVC, passenger compartment attack. She had some neck pain immediately after the accident. That then resolved. Vitals is below, and her exam is unremarkable, including no midline spinal tenderness. We'll move on to case two, and then we'll discuss each of these in turn. So case two, you're dispatched for bleeding. Patient is a 24-year-old male who's preparing dinner, cut his left thumb with a knife. Vitals is below, and he's got a 4-centimeter lac along the lateral aspect of the left thumb. Full range of motion there, normal capillary refill. Case three, you dispatched on a fall, and there's an 81-year-old male who tripped and fell to the ground. Oxygen was knocked off. He'd been lying on the floor for an hour, and then a roommate heard him. Vitals is below, notable for heart rate 130 and respiratory rate of 30, and his exam most remarkable for a right knee abrasion. So each of these are patients that could refuse care. And so we're going to talk about how we approach that when you have a patient who's wanting to refuse care. So the first step is to establish the decision-making capacity. This could be a whole lecture in itself, but I'm going to summarize with the two key things. Decision-making capacity depends on the significance of the decision being made. And so you need a different decision-making capacity to refuse if you just stubbed your toe or if you are having severe chest pain. Someone who's intoxicated and stubbed his toe has a fairly low risk of something going on with him. And so that person saying, oh, I know I don't want to go to the hospital, is a very different situation than the same person who is complaining of severe chest pain, says he doesn't want to go, but you have questions about his ability to understand the implications of that decision. And so that gets into the second aspect, which is depends on their ability to understand the risks and the benefits of the decision being made. And so in general, the documentation that we review on this is very good. And the places where we fall down mostly are when we don't do a chart and don't document that we had this conversation with the patient, showing that they had that ability to understand the risks and the benefits of refusing care. if you have a surrogate decision maker, these same things can be true for the surrogate decision maker. So say you establish that the patient has capacity. How do we approach that in our system? So then the next question is, you need to determine through your history and physical exam whether there's a medical need. So if there's no medical need, then you document in the chart how you interviewed the patient, how you examined the patient, and how you got to the point that there was no medical need. If there's a minor medical need, then you are going to document in your chart how you got to that point, and then that person would fill out a refusal form saying that they're refusing transport for the care. If there's an immediate medical need, then you're going to do the same chart. You would contact medical control to bring all the resources to bear that you can to try to convince this person to go and to make sure you've done everything possible to convince them. And then you document the refusal form. So for case number 1, this is the 25-year-old female who had neck pain that then resolved. You can either feel free to either speak or to put it into the chat. In this case, do you think there's no medical need, a minor medical need, or an immediate need? And so what I'm hearing, so this is a case I'd argue there's no medical need, but it is very important that the exam be documented to get to the point that you arrive that there's no medical need. This is someone who has no complaints, but we need to have a chart on file demonstrating we examined the patient, she had no spinal tenderness, there's no medical need for further evaluation. Next case, case number 2, the man who cut his thumb with a knife. So I would argue here, there is a minor medical need. This is someone who's neurovascularly intact, but has something that requires medical attention. He could go by private vehicle. He could go to most urgent cares with something like this, but it's still, he has something that would be treated in an emergency department. So if he's refusing transport, we would ask him to sign a refusal form. Then in the last case, I think we can all agree that in this case, here's someone who tripped and fell, has abnormal vital signs, was weak enough that he couldn't get off the floor by himself. And so here there's a clear medical need. And so if this patient is refusing transport, you want to thoroughly document all of the things that you did to try to convince him to go, the risks and the benefits that you discussed with him, and then you want to involve medical control. So with that, I'll go on to the take-home points for this portion and take any questions. So number 1, we're seeing refusals increasing during the pandemic. One of the first step, if you're contemplating doing a patient refusal, is to establish the decision-making capacity and to document in your chart how you got to that point. And then the final point is that you have to assume that there is a medical need unless the documented history and physical shows that there is not a medical need. With that, I'll take any questions on refusals before we go on to the next part of the lecture.
Marlo.
Yes.
Hi, this is Jackie. I wanted to pose a question on maybe some direction on recommendations for patients that someone calls an ambulance for, let's say for nausea and vomiting, reportedly bloody vomit. The patient who got there says that they didn't call. It's some other reason for why they're vomiting, maybe For example, for a recent case that I've reviewed was related to drinking a soft drink, and they have no interest in getting vital signs or providing any additional history. What would you want the medics to be doing? Do you want them to document this as a not needed? How would you want them to document somebody who is unwilling to provide any additional information, suspected medical cause, and they won't let them get vital signs?
So just to clarify, the patient's refusing evaluation, doesn't want to be touched.
Their family member called for them.
Yeah. So I think it's really important to document how the call came in and what the person who made the call is reporting. And then you can obtain a significant amount of exam even without touching the patient. And so you can document that this person is sitting upright, that they have clear speech, that their skin is well perfused, that they're alert and oriented. And then you can say, we recommended transport, or we recommended further evaluation, and the patient refused. And at that point, if you have someone who appears to have capacity, understands the risks, and doesn't want you to lay a hand on them, then you have to honor their wishes. But you would want the chart to document all those elements, that both how the call came in, why the person has capacity, what you obtained on your physical exam, and what your decision was to make the disposition that you chose.
Okay, great. And would you, let's say, for example, same case, you gather additional information that there clearly is bloody appearing emesis next to the patient. Would you want EMS to call for a medical documentation of a refusal AMA, or would you just want it to be written in the electronic medical record?
I mean, I think if the information suggests to you that this person could be having bloody vomit, and they're refusing any further care, then I do think it's helpful to involve medical control, because when you're documenting in real time what you're doing, to presuming if the patient is willing to speak to the physician, then you have another point of view trying to get the patient to permit further exam. And if you call and you talk to a physician and you offer the patient the opportunity to talk to a physician, and that patient refused that opportunity, then that demonstrates that you had a significant concern for the patient. You did all the things in your power to convince them to go to the hospital, and you were unsuccessful.
Great, I agree with those same points as you're mentioning.
Other questions? Okay, then we'll move on to the next topic. So this will also be a brief and focused review, because we're dealing with, I think we all at this point are fairly familiar with the primary manifestations of COVID, but there are some other rare complications that we are likely to see at some point, especially as we continue to have more and more cases. And so this is the multi-system inflammatory syndrome in children, and we're going to focus in on what matters for EMS. There's a news item from the end of May noting the 5th child in Washington state to have the COVID-related inflammatory syndrome. So this has not been common, but definitely as we have more and more coronavirus cases, we are seeing more and more cases of this. So I think it's important that we just have a basic awareness of what it is and to be able to screen for it in our evaluation. So this is what we're going to cover. What is it? How does it compare to Kawasaki disease? And then, importantly, what is Kawasaki disease? And then what are the things that we need to look for? So here's the case definition for MIS-C. So you need a fever of greater than 100.4 Fahrenheit for greater than 24 hours. Laboratory evidence of inflammation. And so that highlights that this is not a diagnosis that we're going to be making in the field. but it's something that we have to suspect based on the clinical information that we have. There are greater than 2 organ systems involved, and we'll get into what that looks like later. There's not another plausible diagnosis. And then either they're tested positive for COVID-19 or have a known exposure. And so a lot of the literature about this compares it to Kawasaki disease. Kawasaki disease isn't something that we talk about frequently in EMS. So here's a quick review. So Kawasaki disease is one of the most common causes of vasculitis in children. It's usually self-limited, but 25% will go on to develop complications. And so as we're thinking about particularly in kids under 5 who have fever that lasts more than 5 days, there are a small number, but we see them every year, who have this complication. And so if they develop Kawasaki disease, the complications include coronary artery aneurysms, they have depressed cardiac contractility, and can go into shock with heart failure and arrhythmias. And so obviously we see many kids who have fever more than 5 days, but the kids who have the combination of fever for more than 5 days, red eyes, they typically have swollen lymph nodes and a widespread rash. And then they typically have some changes to the mucous membranes. It's the classic finding is called the strawberry tongue, where the tongue looks very red and then has these small white dots on it. So that's Kawasaki disease. And like I said, typically in children under 5. So how does MIS-C compare to Kawasaki disease? So Kawasaki disease, primarily less than 5. For the case definition, it requires more than 5 days. And it is typically the primary illness, meaning that they started to have fever, and then 5 days after that, they started to develop these other symptoms. But in MIS-C, and this is the thing that I think is really important for us in EMS and emergency medicine, it primarily affects kids that are 5 to 13. And that's really unique about this, because in general, in a vaccinated kid between 5 and 13, there are very few infectious diseases that are gonna make them very sick. The fever, as we talked about in the case definition, can be greater than or equal to 24 hours, but it's usually at least 4 days of fever. And then there's previous COVID exposure, usually within the preceding 2 to 6 weeks. So this is coming after they've been sick with something else, rather than having the primary illness as it is in Kawasaki disease. So what does MIS-C look like? So it's multi-system inflammation. So we were talking about the case definition, including more than 2 organ systems. So similar to Kawasaki disease, they have the injection, and they can have the red and cracked lips, cervical lymphadenopathies, and rash. What they also tend to have is this plus one of these other things over here. So some kind of neurologic sign, it could be an abnormality in gait or an area of weakness, some respiratory distress, which is fairly rare with Kawasaki disease, some sign of left ventricular dysfunction. And so I think this is really the key thing to hone in on in our exam. Is this kid shocking? Is there any sign that this kid is having early shock? And as you remember, kids can compensate for some time with shock, but then tend to get worse. And so you want to be looking for the early signs. And then many of them have some kind of digestive involvement, usually nausea and diarrhea. So what matters on your exam? So you want to document the duration of the fever. You want to document your skin exam, especially just taking a look inside the mouth. Here's the classic strawberry tongue, but probably the single most important exam finding to document for EMS is the capillary refill. Because that's going to be your earliest indication that the kid is developing signs of shock. And we typically don't think about checking capillary refill and looking for shock in a healthy school-age kid. But I think with this in the mix, I think that's a worthy thing to add to the exam. And then you want to document something in the neuro exam. It can be fairly, it doesn't have to be super detailed, but it can be descriptive. They were playing, they were walking around, they were using all their extremities equally. There's some description of what the neurologic status of the kid is. So take-home points on MIS-C. So it's a rare complication of COVID-19 infection, occurs 2 to 6 weeks after the primary COVID-19 infection. Most common in school-age children, can happen in kids younger than 5 and kids older than 13, but the vast majority of the cases that have been documented have been in that 5 to 13 range. And it can lead to shock and cardiovascular collapse. So these are the cases that we're hoping to pick up as early as possible. And so if you're examining a kid in his age group, be sure to include those key exam findings, especially capillary refill. And with that, I'll take any questions on MIS-C.
So Marlo, this is Mark. Treatment for these kids is supportive, essentially, right?
Correct. I mean, EMS treatment is definitely supportive. In hospital, there are some other options, but the vast majority of the treatment for these kids is supportive. And the key thing is recognition, and recognition early, because with some early treatment involves things like IgA. These kids in general have done well, but where these kids have really struggled and had prolonged courses are when there was a delayed recognition. Then there's a question in the chat. Is there enough data yet to suggest what percentage of children may develop MIS-C? It sounds like it's very low. So in Washington, we've had several thousand cases of COVID-19, some percentage of those amongst kids. And right now, to my knowledge, we've had 6 cases in the state of Washington. So it's probably 1% of less of all COVID infections. So I don't think this is something that we're going to be seeing every day, but I suspect that over the next year, we will have at least 1 or 2 cases in Clark County. Other questions? The question is, do I think it will rise when kids return to school? I think it's likely that there are going to be some increase in cases when kids return to school. In general, it seems like the vast majority of cases are pretty mild, which means that they may have it asymptomatically, but there probably will be some increase. That's why I say I suspect we'll see a case in Clark County in the next year, but we're still talking about very small numbers, and there's still a lot of limitations about what we know about this. Any other questions? Well, I really appreciate your time and attention. I welcome your feedback. We certainly want to make these educational programs the best possible for you. You can either scan this QR code or I put a link in the chat to a 2-question survey you can give about this. Welcome any feedback. We want to make this education as good for you as possible, and really appreciate what you do. Thank you.
Right, thank you.
Thanks, Dr. Mark.
Hey, Mark, can I chime in? I've got just a couple things to discuss.
Yeah. Yep.
Okay. Actually, it's only one thing. I just wanted to make everyone aware that we have one person under isolation right now for exposure, but it was not an exposure at work. It was an exposure to community, actually to his parents. But and to my knowledge, he's not had symptoms at this point, but that's neither here nor there, because if you're exposed without any protection to a confirmed case, it's a flat out rule now. That's a 14-day isolation. Now the rules have changed. If you say, well, gee, it used to be that if I got sick, tested positive for COVID, I could go back to work if I had no fever for 72 hours without use of any antipyretic medications, and even if my symptoms were improving, I could, and then if my symptoms were improving, I could go back to work if I wasn't otherwise sick. Well, that rule has changed. If you get sick now, the rule that you are considered non-contagious after 72 hours after fever breaks, plus it has to be at least 10 days since the onset of symptoms. So let's argue that you are exposed to someone because you didn't do good PPE, and they're testing positive, and we determine you don't have enough, you didn't have enough protection. You go on home isolation. Then if you become sick, you get a test. If you're positive, then you're at continued isolation for at least 10 days. So if you get sick 7 days after your exposure, then you're off work for 17 days. That's the thing. So this is still, the guidelines are you have to be really at isolation. You have to be really careful. It's not just, it's a minimum of 14 days. There's no way we can get out of this. So be careful. Take all precautions, stay out of crowds, stop going to those raves, and be safe out there.
Anybody have any questions for Dr. Whitwer?
Such as when will this all be over? Probably it'll be pretty stable next summer.
Okay, well, thanks everyone for coming. I would reiterate the stay safe out there part, and hopefully get a chance to enjoy the nice weather. And we'll see you again in a couple of weeks. Dr. Gadbois will be doing case reviews. We'll send out the invitations are already out. So we hope to see you then.